Hello, everybody. I'm Dr. David Casey, Chair of Psychiatry and Behavioral Sciences at U of L. Welcome to our Grand Rounds presentation. Fortunately, we're virtual today, so not only are we free of risk for COVID, but we're free of risk from the ice storm also. So that works out in our favor for the time being. Today, we have a very distinguished speaker, Dr. Joseph Niemandt, who is Chair of Neurological Surgery at U of L. Dr. Niemandt studied at Dartmouth and Duke and did his residency in neurosurgery at Mass General Hospital, a Harvard affiliate, and a fellowship in neuromodulation in Toronto. He was a faculty member at Vanderbilt before coming to U of L. And he has a longstanding interest in sort of that area on the border between psychiatry, neurology, and neurosurgery with neurosurgical approaches to neuromodulation, and has also worked in other fields, including movement disorder, epilepsy, some basic science research on brain function related to those areas, and has served in a number of important positions in American and international neurosurgery. So it's our great honor to have Dr. Niemandt with us today. And he is going to talk about neurosurgical approaches to neuromodulation. And I'll turn it over to Dr. Niemandt. Welcome.
Okay, well, thank you very much for having me. It is a pleasure, really a pleasure to speak to this group. As David mentioned, I really started my career with a very strong interest in neuromodulation for psychiatric disease. It's been an important part of my career and something I still think a lot about. So I'm always very excited to talk to people in psychiatry and explore touch points where we can work together. I'm sorry I'm not there in person. I wish at some point, hopefully we can all be together and discuss these things more easily. I'm going to try to share my screen if I can. We'll see if this works. Okay. So let me know, is everyone able to see that? Does that look all right?
Yes, sir. It looks good.
Wonderful. Okay. So, I'm going to do a few things. So I'm going to talk broadly about neuromodulation. I'm going to start with some of the history. Neurosurgery has a very storied history of treating psychiatric disease, and I think it's a fascinating topic. So I'll start by sort of walking through a lot of that history, touching on some of the first uses of neuromodulation, which began actually, in the 1950s, which is somewhat remarkable. And then carry us up through sort of the studies in the last 2 decades that have guided the surgical field of neuromodulation, and maybe some of the sort of future ways in which we might approach this. This is paralleled by something I won't cover, which is non-invasive neuromodulation. And I was mentioning to Ali as we were talking before we got started, that I think is a parallel area of investigation and literature that is fascinating. And I've been struck many times in my professional career by how disconnected these two fields are. And so I think anything that we can do as neurosurgeons and psychiatrists to kind of have conversations about this, I think will benefit the field and benefit our patients. So with that, I'll get started. Okay. Let's see if I can advance. Okay. These are my disclosures. I do sit on the scientific advisory board for Abbott and Boston Scientific and some other companies. I'm funded for research that is none of which is directly related to what I'm going to discuss today. So introduction. I've mentioned a little bit, my interest in this field. Usually, when I start talking about this, I'm giving this talk to neurosurgical audiences, and I have to convince them that psychiatric disease is a problem, is important, right? And so, if you just look at the numbers throughout the world, psychiatric disease is really the largest contributor to disability. By comparison, you have depressive disorders, 322 million people worldwide. Anxiety disorders, 264 million. But by comparison, brain tumors, which neurosurgeons like to think a lot about, is about 250,000. So it's several orders of magnitude smaller in its impact. And as I don't have to convince this audience, psychiatric disease is tremendously debilitating. Some of the saddest stories I've seen of patients I've seen have been patients suffering from very severe depression or OCD. And that's represented also in the suicides that you see in these terrible diseases. So This is clearly something of great importance, and I think something that some people in neurosurgery have started to recognize as an important thing to address. This again supports that point. If you look at sort of the top 10 causes of disability worldwide, this is an older report that I had. I couldn't find the most recent list, but you see that there really are not the things that we think about as neurosurgical diseases, aneurysms and brain tumors, don't make the top 10. I think they fall down in the 50s. But depression, bipolar disorder, schizophrenia, OCD, alcohol abuse, psychiatric disease is a huge contributor. It fills the top 10, and so. If we have some ability to treat the most refractory patients, that will be important for the individuals that we treat. In thinking about this, so this is a slide that I was given by a leader in neurosurgery who was not a functional neurosurgeon about a decade ago. And what he was saying was, hey, if you look at what we treat today and what we are going to be treating, it's going to shift dramatically. Right now, we think a lot about spine and cranial and things, but in the future, it's going to be psychiatric. It's going to be functional restoration, and so the impact that neurosurgeons can have in this area, I think, is substantial and something that I have always thought in my career will be growing as we move forward. So with that sort of future thought, let me take you back a few centuries, and we'll talk a little bit about. Sort of the growth of the treatment of psychiatric disease, through our sort of storied history. Treating psychiatric disease is not a new idea. So there is a lot of evidence of trephined skulls that occurred as early as 5000 BC. This is just one example. There are other examples from South America, and I'm sure others. This practice, which was not done for any brain surgical intervention, but theoretically just to release spirits, was maintained even into the sort of the Renaissance Europe. So this is a sort of a famous painting, at least among neurosurgeons, Jean Debray, The Cutting of the Stone, which demonstrates the trepanation there around 1660. So that was the practice really for centuries. Starting in sort of the 1800s, people began to assign function to different parts of the brain. And this was first done in this, by a method that was somewhat clumsy, was this idea of phrenology, where the different shapes of the skull might indicate different behaviors. And although we don't think those measures and such were accurate, the idea that function could be localized was an important stepping stone toward really modern neurology. And so, from that idea of phrenology, which sort of came about in the 1800s, people began to think about brain function as being localized in different parts of the brain. And there are a handful of examples, cases that really provoke this. So, one is this very famous case of Phineas Gage, who was a gentleman in 1948 who was working on the railroad and had this long tamping rod by which he would pack gunpowder into the side of a hill they were trying to tunnel through. And on this particular day, he accidentally ignited the gunpowder, and this thing shot through his skull. This is a cartoon of the tamping iron and the skull that was later recovered. He lived through this remarkably, and famously, Antonio Damasio, who was a neurologist, published this paper in Science where he found the skull, which had been on display at the Harvard Medical Library, and reconstructed what the injury must have been and what parts of the brain may have been destroyed. The story, for those of you who haven't heard it, is that this gentleman, famously had this injury, woke up on the scene of the injury, was taken to a local doctor who examined him, and although he had this, rather significant wound, was alert, communicative, and seemed at that time to be just fine. Didn't have any motor deficits, didn't have any significant limitations. He later went on to exhibit significant, what we would now call frontal behavior, where he, exhibited terribly poor judgment, could not relate, although he had previously been a sort of a very calm and regular sort of individual, family man, began to exhibit sort of aberrant behavior and was unable to hold a job, unable to keep his family. It was a very sad story. So this particular injury, I think, did influence the way people began to think about what the brain does and where functions and behaviors and judgment and such is localized. Around the same time, you had the presentation of, Broca and Wernicke and others began to assign function to different parts of the brain based on strokes and other injuries that had limited the ability of individuals, patients who had suffered from injuries in those areas. And so again, this expanded the idea that different parts of the brain do different things. At the same time, to sort of understand the next step, it's important to understand a little bit about where psychiatry was at the time, what tools were available. So if you look at the turn of the 20th century, there were no significant medications that could be provided to patients. You had essentially restraints, immersion baths. You might induce an insulin coma or induce a coma through cold exposure, et cetera. Later, ECT was forwarded as a therapy. But because of that, you had an exceptionally large number of patients. You had hundreds of thousands of patients in the US who were in asylums, could not be released, could not be treated. And so I think it's helpful to understand it, as I'm sure this crowd does very well. I think it's helpful to know this because it really did influence sort of some of what today seem like very barbaric measures that were taken surgically to treat these patients. So the first of these was reported as early as 1891. And at that time, this gentleman, Gottlieb Bruckhardt, began to explore the possibility that by lesioning parts of the frontal lobes, you might relieve agitated psychiatric patients. And so he reported a series of patients, 6 patients. He had 3 successes, 2 partial successes, and 1 death. As for much of this literature, the definition, the measures by which success was acknowledged or measured is not very clear, and that has sort of marred this whole area of endeavor. Really much of it was physician impression, and so it's very hard to know how to compare that to modern studies of deep brain stimulation and others. One of his quotes, which I think is rather striking, is, he said, there's sort of 2 different doctors. One stands fast by the old principle, do no harm. I belong to the second category. Every path that leads to new victories is lined with the crosses of the dead. So quite a stark image, and one that we might not adopt as surgeons today, but perhaps at that time, was necessary. Certainly was a unique personality to take that on. This area of research in primates was significantly advanced by a gentleman, John Fulton, who was head of anatomy at Yale in the 1930s and really became one of the world experts in frontal cognitive function and experiments looking at the effect of different ablations on primates. And so he had a number of people come through his lab, notably Delgado, who I will talk about shortly. But he began to demonstrate the ability to treat different sorts of disorders and behaviors in primates and to alter those behaviors, limit aggression and such, with frontal resections. He famously presented this work at the Second World Congress of Neurology, which I believe was in Paris. And at that meeting, you had Gaz Moniz, Freeman, and Watts all present. So there was this sort of particular meeting where a lot of what would become the thought leaders in this area all converged. And so it's always interesting to me to think about a single meeting having that kind of an impact. One of the people who really sort of took a leadership in this area is Gaz Moniz. So Gaz Moniz, born in Spain in 1875, really quite an innovator. In addition to really pioneering the frontal leucotomy, he also was the creator of cerebral angiography. He won the Nobel Prize, I think, for both of these interventions, but my understanding at the time was that really frontal leucotomy was a much more impactful therapy at that time in that era with the severity of psychiatric disease that was being seen. And so this was his description of sort of how he thought of the idea and sort of the ideas that were being passed around at that time, that it was necessary to alter these synapse adjustments and change the paths chosen by the impulses in their constant passage so as to modify corresponding ideas and force thoughts into different channels, et cetera. So it's really fascinating about how they were thinking that, and really just as they were beginning to understand brain function, how this idea of intervening in brain function was forwarded. The device that he used, which in retrospect is a rather elegant device. If you compare that to some of the surgeries and frontal lobotomies that I'll show you, what he developed was this idea of making a small burr hole, inserting this leucotome. And what the leucotome was a simple probe with a wire that could be sort of bent out like this. And then if you bent it out, you could rotate it, and that would just create a small circular or spherical lesion in the brain. Not that different from what we do, today in some surgeries, RF or different things. And so this was actually a much more focused approach than some of the therapies that followed. And I think that's interesting. In the U.S., the major pioneers of this work were Walter Freeman and James Watts. And again, they had been at that meeting in Paris in 1936, and pretty much immediately after decided that they were going to bring this to the U.S. They were at GW University. James Watts was a neurosurgeon. Walter Freeman was a neurologist by training, but both had a significant interest in psychiatric disease and began to pioneer a slightly different approach. What they did, what Watts had described, was making a small burr hole just sort of above the Sylvian fissure in the frontal lobe, and using this sort of a leucotome which is just a kind of a soft-edged knife that could enter, into the substance of the brain, and without too aggressively crossing sulci or blood vessels, could be used to divide the fibers there. And so this was essentially a prefrontal lobotomy, and became sort of the mainstay of the early procedures that were done. And they did quite a few. I mean, so compared to, modern studies, they reported on as many as 200 patients and had pretty significant improvement, 63% improvement in that early group of patients. But they did at the same time have significant complications. So 14% were worsened. It's not described what that worsening was, but just that it was not, nor is improvement described, just the surgeon's impression or the physician's impression. They also saw seizures, apathy, confusion, decreased attention, inappropriate behaviors. So that there were certainly drawbacks to these therapies. For that reason, it is said that Watts was less enthusiastic moving forward and did not want to perform quite the number that Freeman, who was quite a zealot about this, was wanting to perform. And so at some point, Freeman decided that he was going to sort of go it alone. And he developed, not having had surgical training, he decided that he could do this rather simply by doing this, transorbital lobotomy. And so he developed this tool that is essentially just a rigid probe. It is firm enough that with a small mallet you can penetrate the skull over the orbit, and you can make a series of lesions in the frontal lobe. And so these instruments are still around. We have pictures in our archives of the World Society for Stereotactic and Neurosurgery. It's kind of a notorious instrument. I was actually given one by a former fellow, and I don't really know what to do with it. It's not the sort of thing I want to put on my wall. But it's certainly an interesting historical technique. He really took this to its logical limit. So he decided that that this needed to be brought to the masses. He wasn't able to treat enough people just being in Washington, D.C. So he got this Winnebago, which he called the lobotomobile, believe it or not, and drove around the country to different medical hospitals and performed this on a series of patients that, at every place where they might have 10 or 20 patients waiting for him, and gave these sorts of demonstrations with many people sort of sitting around and watching this technique. And these are some of his comments, surgeon's knife restores sanity to nerve victims, wizardry of surgery, perhaps it's for headlines, restores sanity to 50 raving maniacs. I mean, clearly sensationalized. That this is not, you don't get the sense that this was good, thoughtful, engaged judgment, which is unfortunate because it really did lead, I think, to, there were some patients who had been helped by the previous surgeries. And this sort of thing really did cast quite a, a negative image over the entire endeavor. As the era of psychosurgery sort of drew to a close in the 1960s, and I'll mention that in just a moment why that occurred, there was a very influential review written by Tooth and Newton, and so they actually reviewed, and I don't know how they got these records, but more than 10,000 patients who had had these surgeries, and then cataloged how they had done. They described 70% improvement in quotations, although only 18% were able to leave the hospital. So it's questionable how much that improvement was. 6% mortality, for neurosurgery in that era, that is high, but maybe not as high as that would seem today. 1% epilepsy, 1.5% marked disinhibition. So, in a population that really had no other options, this is maybe acceptable, and that was that was really the sense at the time, was that these surgeries were necessary given the situation, that this was a last resort surgery that needed to be used. But around this time, so as the sort of 1950s came, several significant things happened. Probably the most important of these was the introduction of chlorpromazine. And so now, having a significant medication that could be used to treat patients, the need for performing surgical interventions was dramatically less. And as neuropharmacology has improved and grown over the subsequent decades, the number of instances in which surgeons are thinking about or asked to intervene in psychiatric disease, whether it is depression or schizophrenia or OCD, et cetera, is exceptionally rare. It is the 1%, the very small percent that don't respond and who are very, very severely debilitated. There were also a handful of sort of important stories that entered the media. The first was Rosemary Kennedy, which was a daughter of, sister to John F. Kennedy and Robert Kennedy, who I think had some developmental delay, had some perhaps aberrant behaviors, many of which may have been just what would at the time be regarded as hypersexuality. And her father, Joe Kennedy, decided that she should have this procedure, and she was damaged by it. So that was something that entered the media and was obviously very upsetting. There's also the movie One Flew Over the Cuckoo's Nest, which prominently features Jack Nicholson as a psychiatric patient who is sort of enters a psychiatric ward in order to avoid some consequence, and ends up having, among other things, ECT and a frontal lobectomy, and it is very much damaged by it. And so these really cast quite a pall on the practice of psychiatric neurosurgery, and it really started to put the brakes on what was being done. So enter the stereotactic era, and this is sometimes called the first era of stereotaxis. As it became clear that it was not, that these therapies were not going to be broadly used, people began to think a little bit more precisely about how one might intervene in the few patients who really did have relatively severe disease, would be a depression, OCD, et cetera. The idea of the limbic circuitry in the brain was forwarded by Pabst in 1937. It was refined in 1952, again around this time, by McLean, and expanded to include areas of the frontal lobe, insular cortex, and temporal cortices. And so this began to give sort of an explanation for how these frontal lobotomies, lobectomies, et cetera, had potentially been functioning. We began to have a mechanism to support the observation that some of these patients were getting better. And with that, people began to think more precisely about how surgeries might be created. And this is really the rise of stereotactic surgery generally. So stereotactic surgery, which began and is still used very routinely in movement disorders, began for movement disorders, but also quite largely for the treatment of psychiatric disease. This is sort of a famous picture that is handed around among functional neurosurgeons like myself. In 1947, this is the use of the first stereotactic frame. Those frames were developed for animal use in the late 1800s. by Victor Horsley and others, but were really first applied to patients in 1947 by Spiegel and Wykes, who were a neurologist and neurosurgeon pair who worked closely together. And that first surgery, which is, this is meant to be the first picture of surgery, was a dorsal medial thalamotomy performed for a psychiatric patient. So really at the very beginning of stereotaxis, psychiatric interventions were at the center of it. And really the breadth of this literature is dramatic. Almost anything that has been tested recently with a deep brain stimulator electrode, lesions were made in the historical past, and they are everywhere. There are also publications with electrodes placed broadly throughout the frontal lobes and tests being done to sort of map out where emotional centers might lie. One that was proven to be relatively efficacious was the cingulotomy, and this is still very rarely used in very severe psychiatric disease. This was really pioneered by Tom Ballantyne at MGH. And he introduced a somewhat more modern technique where he used ventriculography so that he could actually see something on an X-ray of the brain anatomy. And he would then essentially freehand insert an RF thermocoagulation probe. And as this was described to me, so I trained more than a decade after Dr. Ballantyne had passed on. But his successor was Rhys Cosgrove, who was very much my mentor. And what Rhys described was that they would line things up. They would put the probe in. They would turn the thermocoagulation on until they heard a pop, and that's when they knew they had done an adequate lesion, and then they would move to the other side. So, still a somewhat barbaric surgery, here in the 1970s, 1980s. These are some images from a modern cingulotomy. The location is still very similar. Stereotactic techniques with frames were later applied and used more productively. Today, we do this surgery rarely for very severe pain syndromes, cancer pain and such, and even more rarely it is done for significant depression or OCD. Other lesions that were performed during this time. So Telerak introduced the idea of a capsulotomy with the idea of dividing fibers between the anterior thalamus and frontal lobes. This was the target that he used. And then subsequent to that, others introduced the subcaudate tractotomy, lesions sort of just below the caudate here in the septal area, and then relatively close to an area that we're going to talk about, which is the CG25 or subgenual cingulate. They may actually have been the same target. That's sort of a question that some have raised. And then there's a limbic leucotomy, which was a collection of lesions in the cingulate and subcaudate regions. It was pointed out to me when I was training that if you look at where these targets are, so here, these are the targets for a limbic leucotomy. This is the subcaudate tractotomy. If you actually look at the frontal lobectomies that were being done, in the 1930s and 40s, it's pretty clear that they end up dividing these same pathways. That if this is done effectively, it divides areas in the subcaudate region and in the cingulate, and so it may very well be that what more modern surgeries identified were sort of the key pathways that were needing to be disrupted. And that idea of having sort of key elements of a circuit is something that we will get back to with our modern stimulation surgeries. And so, yeah, you can see here how this might have been severed in the same area. Also in this era, so I was sort of, it struck me when I was training, and sort of thinking that DBS was invented in 1980 by Dr. Benevit, to find that there were papers as early as the 1940s that described the use of electrodes in the operating room to treat patients. This started, as far as I know, in 1948 with J.L. Poole at Columbia University. One of his trainees was a gentleman, Robert Heath, who went on, left New York and went to Tulane University, where he was attracted to build sort of a center of psychiatric surgical intervention. And so he went on. If anyone is interested in this area, this book, written by Lone Frank, is a wonderful, interesting account of some very interesting surgery. And I think gives a pretty balanced account. He certainly made some missteps. He did some things that were very controversial, and this book describes his treatment of a patient with homosexuality and wanting to reverse that in some way. But also made some, I think, very seminal contributions to the understanding of the frontal sepal area. And so it was important work, much of which has sort of been lost or is unknown. And so it's a very interesting read. Another person sort of experimenting with brain stimulation is this very interesting individual, Jose Delgado. Jose came from Spain and worked in John Fulton's lab at Yale, where he was primarily interested in modulation of aggression. And in 1965, having done this work on a number of primates, he gave this charging bull demonstration. He went back to Spain and arranged for there to be a bullfight with a matador. And I'll show you a video of this, which I think is interesting. Hopefully you guys can hear that. Can you hear the video?
Dr. Jose Delgado demonstrated remote control over a charging bull. By connecting a radio antenna to electrodes inserted into the bull's brain, Delgado proved that the animal's aggressive impulses could be thwarted by electronically manipulating the bull's muscle reflexes.
You realize the fantastic possibilities if from the outside we could modify the inside, could we give messages to the inside? But the beauty is that now we are not using electrodes.
In recent years, Delgado has shown that the behavior of monkeys can be altered using low-power, pulsating magnetic fields. But in these experiments, there were no antenna implants.
Any function in the brain, emotions, intellect, personality, well, could be perhaps modified, that is not in basic technology.
Delgado.
Okay. So you get the idea. I mean, it's interesting to me. One, I think his dedication to research exceeds my own. I have not stepped into any bull rings lately. Two, in addition to developing this therapy, he was also developing something like TMS, which is rather striking at that time. But what was, very much problematic about it was that he talked about the use of these devices, not just for animals or not just to treat patients who were seeking treatment, but also to create something he called a psycho-civilized society. And this is, certainly scary in any era. It was particularly disturbing in the 1960s when there was a great deal of social unrest and a lot of, certainly a lot of hesitation that this could be used for nefarious purposes. And so this was sort of there was a second sort of wave of backlash against psychiatric surgeries or psychosurgery. And so in the 70s, there were these, pretty substantial protests, Psychiatry kills. These went on, I can remember very clearly. I was an intern in 1998, and I can remember very clearly walking to work one day as an intern and seeing a whole group of people with signs held up that said lobotomies performed here, because MGH was still one of the centers performing singulotomy. And I put my ID in my pocket, which said neurosurgery on it. I went and talked to one of the guys, in front of the building, and heard him out. Well, he was very upset that these things were going on there, and patients, by his measure, were sort of being dragged into the hospital and treated in some way that they wouldn't want, and then sent off. And so this was a very real concern, in the 70s and 80s. In Japan, these protests were so great that psychiatric neurosurgery is still banned in Japan today. And I believe in Oregon, there is also a state law that limits its use. So it does have repercussions that exist even today for deep brain stimulation surgery that might be used for psychiatric disease. This rose to the point that this actually was brought before Congress. So in 1997, there was a National Commission for the Protection of Human Subjects that had a hearing on psychosurgery. And after sort of discussing and looking at all the evidence, they actually concluded that the data was, that they had previously prejudices that this was a terrible idea, but actually found that some of these things, had been very useful and the operation should not be banned. They recommend that there be, IRBs approving any overseeing any surgery, and that there should be a National Psychosurgery Advisory Board. The advisory board was never created, but I think this sort of these conversations that occurred in the 1970s, are still very much at the forefront of the mind of people who were doing studies in the last 20 years, which is what I'll get to next. So having spoken quite a lot, I might pause and see if anyone has questions about this. Do people want to? We open it up for discussion for a few minutes, and then I can get back to droning on in front of you.
Dr. Cottle, what do you think? Should we open it up right now? Should we continue? I know we're at 10 minutes after 12.
I think we've got more time. I don't think we have to open it up just yet if you want.
Okay. All right. We'll continue on, sir.
Okay, I will keep going. So with that is sort of the most recent, or the more distant history about lobotomies and psychiatric surgeries and such. The next era really begins to consider neuromodulation, and so this is sort of the history of the last 20 years, which I've had some. This is sort of the era of my being involved in neurosurgery. I was a resident starting right before 2000, and so saw some of these things happen and was involved in some of the conversations, at least, that went around this work. So, if you look at around the same time, deep brain stimulation what really came into common utilization in the late 80s, early 90s, first in Europe, and then came to the US really at the end of the 90s in 1997, 2002, 2003, for these indications. Essential tremor, Parkinson's disease, and then dystonia, which is a humanitarian device exemption. Many centers, as they were beginning to use these therapies for movement disorders, began to apply it also to psychiatric disease. Really, the first being Tourette syndrome, and I'll speak about that because it sort of sits at this boundary zone, perhaps between neurology and psychiatry. And then others being obsessive compulsive disorder, major depressive disorder. And there have since been, there's a lot those are the ones that I'll cover in this talk. There's been work on anorexia, there's been work on addiction more recently. There's a lot that we could continue to discuss, and the number of trials that are currently ongoing are substantial. But to sort of roll it out as so this was sort of how DBS was adopted. So it really was introduced in the U.S. kind of around 2000. And then just an increasing sort of investigation and comfort with it that expanded both the utilization of it in movement disorders and the number of other diseases to which it was being applied. And then here's the growth of the number of cases done. If you actually look at this, is broken down into all the different indications, and what you see is that the majority of these are still Parkinson's disease and essential tremor, a little bit of dystonia. At the very bottom of this, you may not be able to see on your screen, there are a bunch of little lines of different colors, and that is depression and OCD and epilepsy all kind of packed together. So those indications really have not become mainstream, although they have been extensively investigated and discussed. With some of the challenges of the 1960s and 70s in mind, individuals who were really leading these studies spent quite a bit of time thinking about the ethics of it. There were ethics papers written about when and how we should intervene in psychiatric disease. People were very careful to say that we really should never be intervening in patients who could not give informed consent themselves. And this idea of making sure that people had adequate severity, chronicity, disability, and treatment resistance, so that you had patients who were severely disabled and had tried really every other therapy before proceeding to the idea of surgery. The group investigating DBS for OCD, there was a collaborative group put together at a number of centers, led by Ali Rezai at the Cleveland Clinic. They put together this, they've actually published a paper discussing these recommendations, that there be an ethics committee, that there be patient assessment committees, that candidates meet all the criteria that we talked about, that patient be able to give its own consent, that all treatment be supervised by a research center, et cetera, putting really backstops so that there really would not be the kinds of abuses that we saw with the lobotomobile or things like that. And then with that, they began to sort of think about how we might intervene and where we might stimulate. So to give you some idea of the underlying physiology of this, this is sort of the roadmap that we use, kind of a simplified roadmap of the basal ganglia that we use for movement disorders. And we sort of know, with Parkinson's being sort of the most the most common, and then kind of the poster child for it. We know that there are these areas in the basal ganglia that are disrupted during the changes that occur in Parkinson's disease from loss of dopamine. The idea was that anatomists had identified parallel circuits that were very similar. So in the basal ganglia, you have a motor circuit, which is represented there in the Parkinson's diagram. You also have a preparative circuit that essentially has the same form, but connects to different parts. So you have prefrontal cortex instead of motor cortex, the caudate, the GPI, et cetera, just different regions, and that each of these, and then a limbic circuit also that sort of serves emotion and depression. And if you look at these, you would, by the same mechanisms, recommend different areas that might be lesioned or stimulated in order to treat disease. And so here you have essentially all of the areas represented on this diagram that have been tested at some point in the treatment of psychiatric disease. And so I'll go sort of through those studies sequentially. So in my mind, this really began in this modern era with Tourette syndrome, because we were treating patients with dystonia and other diseases. And Tourette syndrome has a lot of similarities to dystonia. You have these uncontrolled movements. That the major difference is that patients with Tourette syndrome feel an urge. It is cognizant and it is voluntary. So they feel an urge, they release it themselves by moving in some way, shape, or form, or vocalizing or what have you. And then feel a period of relief. And so it has, by those measures, some similarity to OCD. Anatomists who think about this, Leonard Heimer is a sort of a brilliant anatomist who sort of redefined the organization of the amygdala and its connections to the basal ganglia. There really isn't a natural division between motor function and cognitive function. These things exist in a continuum of behavior that is served by structures in the frontal lobe and subfrontally. And so with that in mind, people began to sort of explore where you might intervene. So Tourette syndrome, is characterized, we've all seen this disease, characterized by these tics that can be suppressed to some degree. There's a lot of comorbidity with OCD and other diseases. It's frequently exhibited in childhood, usually resolves, but about a third remain disabled. Again, an incidence, as much as 5 in 10,000. I think in children it's much higher than that. It was, so we knew something of the underlying anatomy based on previous anatomical studies. PET studies and fMRI studies demonstrated a little bit more refined ways to look at this. But one of the notable studies was performed in which patients were asked to suppress their tics, and they were asked to, we had PET studies performed in periods when they were suppressing or where they were not suppressing. And what we saw was that there was a decrease in activity in the GPI. And so with that, that was one of the targets that was forwarded. The other target, which is the centromedian thalamus, was largely based on historical literature. So if you look back into the 50s and 60s, there were really dozens of publications, typically 1 or 2 patients who were treated for Tourette syndrome with lesions in some part of the brain, be it prefrontal leucotomies, limbic leucotomies, cingulotomies, zona incerta lesions, red nucleus lesions, cerebellar lesions. It's remarkable the extent to which things were simply tried. The best of these studies, which I have read, which is still rather limited, was a report on 15 patients published by Hassler and Diekman in 1973. They were a little bit more comprehensive in the way they described their interventions. They were making as many as 20 lesions in the thalamus, all centered around the centromedian nucleus, or what we know today to be the centromedian nucleus. And they demonstrated improvements that were 50 to 100%, but again, the measures were not, they were not using standardized scales, they were simply estimating what they saw. Based on that literature, Dr. van der Waal in the Netherlands identified this sort of approach where you could achieve similar stimulation to the numbers of ablations that had been achieved in the thalamus. And so she implanted a series of patients starting in 1999 for the treatment of Tourette syndrome. And this has continued, so Tourette syndrome has been really treated at a low level. There have been a handful of patients treated every year. Really since the late 1990s, early 2000s, there was talk for a while that the NIH was going to run a randomized blinded study, but it was felt that there were too few patients with Tourette syndrome sufficiently severe to merit surgery. And so for that reason, it has really remained anecdotal reports. In about 10 years ago, University of Florida took it upon themselves to create a Tourette registry. So many centers like our own who have done a few of these patients, when we treat a patient, we recorded all standardized data and we reported into this registry. To date, that registry they've not published the results. I don't know how many patients they've accumulated. I periodically will call Mike Oken, who runs that registry, every time I have a new patient, which comes up every other year or so. I sort of ask him what the data is showing. Is it leaning toward one target or the other? Central median nucleus and GPI being sort of the principal targets. And then these are some of the other reports. This is the initial GPI report. And I think this was a patient maybe that had both GPI and central median nucleus. So again, most of these report a success rate of about 2/3 of patients responding, but still 1/3 not adequately responding. When I last looked, and there are more now, there were 35 reported studies, 95 patients examining all of these, and again, results were sort of 50 to 75% response. There's a very nice video that was produced. This was a patient who was operated upon at Case Western, and I'll show you this video. This is a demonstration of his. I'll turn the volume down a little bit. You can hear some of his vocalizations and certainly see the tics that he has. And he was ultimately treated at Case Western with GPI stimulation. And had really quite a remarkable response. I mean, he almost, he has absolutely no tics. He sort of walks with a bit of a swagger. You sort of picture him in a tuxedo holding a martini glass or something. I mean, it really, what was just a tremendous demonstration. He was briefly featured in the media on the Oprah Winfrey Show and some other things when this came out. So this was sort of a period around 2006 when there was quite a lot of excitement about the potential of DBS to treat Tourette syndrome, OCD, depression, etc. The next area that I'll touch on is OCD. So OCD, right now affects 2 to 3% of the population, around 3 to 7 million Americans. 10% of those patients are, refractory to the best medical therapies. And so it remains something that is important. The number of patients who are sufficiently severe to really merit DBS surgery is felt to be relatively small. It was estimated by researchers and by Medtronic, who sort of ultimately sought to get approval for this, that it would be less than 4,000 patients per year that would potentially qualify for OCD. And as a result, they applied for a humanitarian device exemption. So it was ultimately approved by the FDA. I think that was in 2007. But approved in such a way that it was never subjected to a randomized controlled trial. And the data we have is still relatively sparse. And so, some of this was based on, sciences with PET and SPECT studies demonstrating increased metabolism in the orbitofrontal cortex. The idea of the intervention, which was based also in part on the history of doing capsulotomies for OCD, which can be very effective, that by stimulating in this region, you are able to disrupt sort of aberrant circuitry, overactive circuitry between the frontal lobe and regions of the thalamus that may support that circuit. And so this is really a summary of the studies that have been done. Again, it ranges. Well, this was early on. Excuse me. There have been many more now. The early studies ranged from 1 to 6 patients. Those that were a little bit larger saw as much as sort of 2/3 improvement. Different targets were selected, the most common being the VCVS target, which is the anterior capsule and ventral striatum. Other targets included the internal capsule, nucleus accumbens, and the caudate. And again, whichever studies you look at, the results seem to be similar. About 2/3 of patients are responding. The result, tends to take 3 to 6 months to get full effect. Medtronic developed actually sort of a specialized electrode, thinking at first they had to sort of stimulate the entire capsule to do this well. They produced an electrode that is much longer. It's 3mm electrodes, I think, spaced by 3 or 5 millimeters, called the 3391 electrode. And I don't know that it's seen any use since. It pretty quickly became clear in individuals who were doing this that much more focal stimulation really at the base of the anterior capsule and in the ventral striatum was sort of the key portion of that target. Here's a similar study looking at the nucleus accumbens, which is a similar area, perhaps just a little bit in front of the VCVS target. And ultimately, based on these early studies, the FDA approved DBS stimulation for OCD in 2009. Again, it was an HDE, humanitarian device exemption. Unfortunately, because of this sort of odd designation of HDE, and I think also because this is a disease that it sort of bridges insurance mechanisms. So that this is a behavioral disorder that is typically treated by that arm of CMS, and yet typically when surgery is being invoked for this, we're used to going through mechanisms that are not used to recommending surgery or approving surgery. So as a result, in my experience and the experience of most of my colleagues, it is tremendously difficult, no matter how clear-cut a patient you have, no matter how refractory they are, no matter how much they should be good candidates for this, it's exceptionally difficult to get these surgeries approved. And so in my experience at least, and I think with the exception of a few centers, DBS for OCD has not been greatly utilized. I still see a few patients who were part of the initial study that was done at Brown University at MGH, and some of them have done well. I have one patient who has continued to struggle and really never responded briefly at the very beginning and did not sustain a response, and then is still in quite a tough way. If you look at studies since, so I wanted to update this with sort of some of the more recent data. So the best data, I think, is a recent meta-analysis that looked at all the studies that were out there. They reviewed now 896 articles, 500 of which were unique articles, and found 40 that had good qualitative, quantitative information. Of those, what they saw was that whether you look at short-term or long-term studies, you still have actually a relatively good response. You have baseline Y-box scores in the mid-30s that reliably fall on average to the high teens, 17, 18, and that's been sustained in the long-term group up to about 5 years. And so I think in some patients this is exceptionally valuable, or can be valuable if other all other treatment methods have been attempted. But still, the number of patients that are getting this, I think, are relatively few. There is also a parallel literature on lesioning in the anterior capsule that is done either by radiosurgery or RF, which has similar results of about 2/3 of patients responding and reductions of about 50%. So in some patients, I think, having encountered patients who are sort of in this, unusual situation of having to go through recurrent stimulation and battery changes and adjustments and never quite finding the right setting, I think that is a very troubling thing for these patients, and some of them might be better served, in fact, by capsulotomy. I think it's a discussion worth having with those patients. And finally, I'm going to spend a little bit more time focusing on depression, because that's the part that I've been personally most involved in. So Depression, again, and I'm talking to a crowd that doesn't need instruction in this. There's a huge burden of disease from depression. It is tremendously common, affecting up to 10 million adults, 3% of the population. A substantial portion fail to respond to therapy. Some will respond to ECT that has its own challenges. And again, the other thing to sort of work into this, of course, is that, what is the benefit of TMS and how many patients who are not responding to these other measures might be better treated by TMS, and that may be an additional group that probably should be included in any patient that might be considered today for deep brain stimulation, for invasive neuromodulation. But I think this remains an important population of patients that could be treated. I'm going to start with vagal nerve stimulation. We've actually been trying to be involved in an ongoing study that LivaNova is conducting. And this was really the first neuromodulation therapy in the modern era that was proposed. So vagal nerve stimulation, has been used primarily in epilepsy. And in early studies, the Hanforth study and others, it was demonstrated that it was not only effective in reducing seizure frequency, which it is primarily used for, but in that early group of study patients, they also found that there were significant improvements in mood, which was being measured as a comorbidity, and that improvement seemed to be somehow independent of their improvement in seizures. You had some patients, whether they responded or not to the anti-epileptic effects, they seemed to have responses as far as their mood, which might be important. So based on that, there was a series of preliminary studies that were conducted. And I'll mention briefly, why might this work? We understand at least the epilepsy effect to be an afferent effect, not the distal effect of the vagus nerve, but that you have afferents to the nucleus of the tractus solitarius, which goes to the parabrachial nuclei and other brainstem nuclei in the reticular formation, and seem to modulate cortical excitability, in particular as it pertains to depression. It may have important implications for the limbic system, and that may account for the antidepressant effect. We don't understand this completely, and so it is still somewhat observational. The early studies, which appeared to be promising, culminated in this relatively large randomized control trial that was conducted and published in 2005. It was performed at 21 sites. There were more than 200 patients that were randomized, 50-50 to stimulation or sham. The stimulation period, however, was only 12 weeks, and that may be important because really they did not see a very significant difference in that period of time between those receiving active stimulation, which is this darker box here, and the yellowish box here that was receiving sham stimulation. But really neither one had a very substantial effect. Both had some limited effect during that time. And that perhaps parallels some of what you see as far as VNS stimulation for epilepsy. It seems to take, for whatever reason, a significant period of time until you see the full benefit. And so when this report was published, they missed their primary outcome measure was the Hamilton Depression Scale. They had a secondary self-report of depressive symptoms that did achieve significance just barely. And they sought FDA approval based on that, really emphasizing more what they later recorded as the long-term effects. So if they followed these same patients now with open stimulation out to a period of 12 months, by 12 months, they were seeing a little bit more substantial response rate on the order of about 30% of response rate being a reduction of 50% in the Y-box scores, remission being less than 10, I think. And so remarkably, based on this data, they achieved FDA approval. And so this is an approved FDA therapy and has been since 2005. However, CMS, after reviewing the data and feeling somewhat uncertain about it, and there was quite a lot of debate about what the FDA had done, CMS decided that they were not comfortable with it and decided that they would not support it. And so as a result, until recently, patients who receive VNS for depression receive it, because an insurer is willing to look the other way, or for whatever reason they're able to get it. It is generally difficult to get this approved for patients. My own anecdotal experience in a half dozen patients or so is that in those patients it's worked quite well. And I've had one really remarkable patient who had sort of a catatonic state that would occur with his depression, and then it completely relieved that. So I've been enthusiastic about this therapy, although it's performed relatively rarely. Just recently, more data was published. So if you look here, there was a 5-year observational study. Again, this is not randomized. But again, following a large number of patients, almost 800 patients at 61 sites, more than half of them receiving VNS. And what they found was that at 5 years, they had really substantial improvement in response. So you had 60 to 70% responding and almost 40% in remission with a MADRS scale less than 9. So this more recent data and sort of an accumulation of data and some meta-analyses that were done have convinced CMS to take another look at this. And they've proposed a study called the RECOVER study. I think this acronym sort of this tests the limits of what you can actually achieve with a catchy acronym. There's not a single like first letter in this here, but this study I think is quite interesting. But it proposes essentially with a longer period of observation during which patients are randomized to either sham or full stimulation to really test whether this is an effect of vagal nerve stimulation versus the attention that patients receive being in the previous studies. We at University of Louisville did try to be part of this study. I've spoken recently to some of our compliance people. We ran into concerns, I think, about the way they had structured the study and whether it was fair to patients who were not covered by Medicare. But hopefully, perhaps we can get on board with that study at some point. It would be nice to be part of it. Moving beyond VNS, there has been, again, a large literature on deep brain stimulation for depression. So again, I sort of got involved in this. I was a fellow in 2005 in Toronto, just as they were completing the first series of patients receiving subgenual cingulate stimulation, and was involved in sort of the next 10 to 12 patients that were part of the subsequent study. There have been other targets suggested, and I'll really start with those because we're going to focus more on the CG25 area shortly. So there have been single or double case reports, I think, of patients treated in the inferior thalamic peduncle. Again, this is a fiber pathway that sort of runs from the thalamus, into the median forebrain bundle. There was good evidence from a single patient that they responded to this, and that when the battery died, they went through a period where they were not realizing that they were not receiving stimulation, and their Hamilton score bounced up. So again, these were sort of early preliminary studies. Chris Henn at Mount Sinai published a series of patients on stimulation of the habenula. The first patient, I think, did relatively well, although not as well as some of the other targets with some significant fluctuations. But there's some reason to think that the habenula is wired directly into the median forebrain bundle and may influence the circuit serving depression. Perhaps the most dramatic initial study was this stimulation sort of medial to the STN, anterior to the red nucleus in the median forebrain bundle. This group, unlike the others, had an even higher response rate and had a response rate that was almost instantaneous. Most of the preliminary studies that were done in ventral capsule, ventral striatum, or in CG25, it took several months to see an optimal effect. And that effect sort of topped out at sort of 2/3 responders. In the initial group, this group did much better, and it's perhaps because although they are intervening in the same circuit, that they may be sort of addressing it at a point where those fibers are more compact. And so there was some excitement about this when it first came out. I haven't seen a pivotal study on this yet, and we're perhaps anticipating that, but it's been some time. And this again is their response. So you can see, sort of how quickly, in just a few days, in less than a week, you had many individuals seeing greater than 50% response in their MADRS scale. And then that was really sustained out to, in their early study, out to about 30 weeks. So promising. Not every patient in this small study, it was, I think, 6 or 8 patients involved. Not every patient responded, but I think 4 of 6 did. 7 patients, sorry. There was one study, this is, I think the Berwick study, I think, was at University of Michigan, sort of in the early 2000s. There were 10 patients treated there with nucleus accumbens DBS. Again, perhaps a slightly different target, although similar to the anterior capsule ventral striatum. And in this group, 4 of 6 patients did respond, similar to the other targets. From this, there were 2 large randomized studies that were created. One was run by Medtronic out of Cleveland Clinic, and it was a randomized sham-controlled trial of deep brain stimulation in the ventral capsule ventral striatum. You see here a picture, a postoperative MRI of one of those placements, and this is again that sort of funny DBS electrode that is much longer than the ones we typically use. What they saw in this study, unfortunately, was that there was not a significant difference between the 2 groups, that you had some response, certainly in both, 20 to 25% reduction in the MADRS scale, which was valuable. But there didn't seem to be a significant difference out to 16 weeks between the sham group and the stimulated group. Something to point out is that it is well understood when you do any kind of DBS surgery that there is a lesional effect, that you're just putting the electrodes in the brain, creates some small amount of damage, and for some period alters the physiology in that region. We see this commonly in tremor patients. We put the electrodes in, and before we even attach the battery, patients come out of the OR with their hands, I don't know if you guys can see that on my camera, just about as steady as they could be. So it may be the case that even out to 16 weeks, there was this continued insertional effect. If you follow these patients further out, although it is not blinded, out to about 24 months, they were continuing to see improvement, with reductions out to about 40% in their scales. So, some promise here, but really the conclusion was that there simply wasn't enough to draw a strong conclusion that this was efficacious. The other major target that was explored, and which I have some experience with, having been in Toronto, was the subgenual cingulate. So this was based on work by Helen Mayberg, who was a neurologist, was working at University of Toronto at the time. And she began to notice in PET studies that when you had individuals who had severe depression, were treated with whatever method, whether it was medication, whether it was cognitive behavioral therapy, whatever it was, that they would see alterations, excuse me, they would see alterations in the activity of this region, the cingulate, the subgenual cingulate, or CG25 area. It was also the case that there seemed to be this concomitant activity in the dorsolateral prefrontal area. When they saw sort of periods of depression, there was more activity in CG25, less in dorsolateral prefrontal cortex. When that was corrected in whatever way, you could see the opposite effect, that you had a reduction in the CG25 area and release of activity in the dorsolateral prefrontal cortex. Excuse me. So based on this data, she approached Andres Lozano, who was my mentor in my DBS fellowship, and said, gee, we've been treating depression and tremor, we've been treating tremor and Parkinson's sort of by what we think is sort of shutting off a circuit or nucleus with stimulation. Could we do the same thing in CG25? And they started with 6 patients, which was published in Neuron in 2005, just around the time that I got to Toronto. And saw that 4 out of the 6 patients responded quite well. They expanded that to a 20-patient open label study, and saw again that you had a very significant decrease in the Hamilton Depression Score. This at that time was not randomized. There was not sham stimulation, and there certainly was a lot of attention paid to these patients. That these patients got, evaluated again and again, and we were doing all sorts of measures on them. And so, like all these studies, the question of is this effect that would occur in a blinded fashion true? They also did with this work the same PET studies that they had done on the other patients, but seeing the effect of CG25 stimulation. And what they found was, indeed, you have in these patients preoperatively this increased activity in CG25 with reduced activity in the dorsolateral prefrontal cortex. Afterward, so you got 6 months out, if you look at the responders, they all had a relatively reduced activity in CG25 and improvement in sort of cognitive functions from dorsolateral prefrontal cortex. So based on this was a study that was sponsored by that time by a company called ANS, which later became Abbott. And they decided they would take this to a multi-center study. So there were 90 patients enrolled over what was probably 15 or 20 centers. I don't recall exactly. We were one of the centers at Vanderbilt. And what they saw was pretty similar to the VCVS study, was that, again, you had a relatively significant improvement, but there was not a significant signal when you compared it to during the blinded period to the patients that were just getting sham stimulation. Whether that is an insertional effect or an effect of sort of the Hawthorne effect on these patients is not clear. If you follow these patients out, and they were followed at that time for 2 years, and they have been followed since, you saw that this effect persisted and even grew, that you had a significant decrease in the MADRS scale that dropped to about 50% of what they had on enrollment, and then their global assessment of function concomitantly improved. And anecdotally, many of these patients sort of went back to work, started jobs, had better relationships with family, et cetera. So the fact that this really did not prove their endpoint and was actually halted before, I think the intent was to recruit 150 or so, really was a blow to the field. We now had 2 failed trials, perhaps because they were not well designed, perhaps because of patient selection. A number of reasons were sort of considered. And there was, I think, in the various companies that supported the kind of this sort of work, a real hesitation to get involved in another clinical trial. At that time, I was had just sort of joined the board for the American Society for Stereotactic and Functional Neurosurgery. We had a series of meetings to discuss this, because this had been what we were thinking of as sort of a mainstay of future neuromodulation surgery, that we were going to be very much invested in treating psychiatric disease as we were currently treating tremor and movement disorders. And so we had a meeting. We put out a position statement that just wanted to reassure patients that we still think there is a way forward here, that we will be able at some point to intervene in psychiatric disease. We just need to do better studies. We need to understand our targets better. Perhaps we need to change the way we stimulate. In 2016, I was involved in organizing sort of a think tank meeting that involved a large number of individuals, scientists who had been involved in this, surgeons that had been involved in this work, neurologists, psychiatrists, neurosurgeons. We also had representatives from each of the big 3 neuromodulation companies that wanted to think about this work. We had representatives from the FDA and from NIH. And we all spent 2 days sort of sitting around a table and talking through this, which was a very sort of exciting procedure. And we kind of got a sense there was a real hesitation from industry that until you had really a positive biosignature, some sort of a signal that you could look at on imaging, or in some such way that you could confirm when you had, as you have with tremor control, you sort of know in the OR when you've hit the right spot, that if we didn't have that, or didn't have a better way to intelligently stimulate, there really wasn't going to be strong interest. And so, this was 2016. It was shortly after I'd started here at University of Louisville. We published a summary of that conversation, and sort of set about sort of regrouping to see what we might do in neuromodulation going forward. And so I'll talk a little bit just about some of the areas that I think are most exciting, and really what I think it's going to take. My conclusion at that time was, we need to do limited studies. We need to actually identify targets and methods of stimulation that are more efficacious And then perhaps once we've worked that out, we can come back and do a randomized trial that's going to be a little bit more directed. And so since that time, there's been some important work that I think has been done. So the first one, again, involved Helen Mayberg, who at that time was at Emory and went up to New York, and involved the work of Cameron McIntyre. Cameron McIntyre is a very skilled imaging electrical engineer who essentially uses MRI to model fields of activation. And what he began to show prospectively in a group of patients that they were treating at Emory was that if you did your targeting based not on our sort of typical method of sort of identifying what we think is the singular gyrus and putting the electrode there, but actually doing DTI mapping on these individuals, identifying where we think stimulation would achieve the optimal effect. And that optimal effect seemed to be that when you stimulate pathways that go both, toward orbitofrontal cortex and toward the amygdala, there seems to be a sweet spot where these fibers cross. And so they sort of worked out the technique of that and then applied that to a group of patients prospectively. And what you see is that in this group of patients, their response seems to be somewhat more robust. They go from a median, this is a Hamilton Depression Scale, in the 20s and drop over 5 to 6 months down to below 10 for most of them. They also saw more responders, where we had previously seen sort of 50 to 60% responders. They were seeing 80% in this small group. And he's now applied this also to epilepsy surgery and then to other studies. So I think this is one element. I don't think this is the whole story. It was, in a non-randomized group, maybe somewhat better than what we had seen in our previous study, but probably not the whole story. In parallel, and actually also involving Dr. McIntyre, two surgeons began the idea of, well, shouldn't we, rather than just sort of shooting in the dark, should we actually test the hypothesis? When we treat patients with epilepsy, we routinely put in depth electrodes and we record to see where a seizure occurs. Could we do something similar and actually test stimulation in a prospective way before we do the final implant? And so this is an ongoing proposal which is funded by the NIH Brain Initiative by Samir Sheth and Nader Peradian at Baylor and UT Southwestern. And what they're doing in a group of patients is essentially implanting them with stereo EEG electrodes, stimulating in various regions, whether it be VCVS or the anterior cingulate, and just seeing which electrodes, when stimulating, are most effective in activating these adjacent regions and concomitantly and perhaps adjusting some measures of their mood and behavior. And so I think this is really a new paradigm for how we might do these surgeries. And then most recently, Eddie Chang at UCSF has essentially applied this same technique and reported a single patient. So he did very much this idea where he put in multiple electrodes, he recorded from some, stimulated from others, and then used essentially a machine learning algorithm to identify which areas, when stimulated, produced activity that was well correlated with, they developed sort of a visual analog scale test that correlated well with the Hamilton Depression Scale and used that to measure in more real time the effect on mood. And what they found essentially is that they identified gamma activity in the amygdala as being critically important to response, and found that when they stimulated in the VCVS region, mood changed when they were able to achieve meaningful depression in this high gamma activity, as opposed to when they did not achieve it. And so I think, and then they went on, if you look at the next slide here, they went on then to implant this device, which is an RNS device used typically for epilepsy, but they implanted it with 2 electrodes, one in the VCVS region, one in the amygdala, one sensing, one stimulating, and showed that in this patient, they were able to identify signals and to stimulate appropriately. If they looked at sort of when those detections occurred and stimulation occurred, it was pretty well tied to this visual analog scale of depression that they were using. And furthermore, that when they actually tested the Hamilton Depression Scale, they saw some significant improvement in this one patient. They point out that this may be simply an N of 1, that this individual, her circuit may be such that high gamma activity is seen in the amygdala, and that's important for her. That may not be the same for every patient, and so this may need ultimately to be customized in some way, as is being suggested by the other team. But it really is a very interesting demonstration, and again, I think this is changing the way that I think about neuromodulation generally. I think in the future we will be much more targeted about not just where we put the electrode, but what we are stimulating and how we're stimulating. And so this is just some images sort of showing this. This is true in really all areas of neuromodulation. We are increasingly putting in electrodes and putting in cortical sensors and identifying phase amplitude coupling and frequency changes that can be used to alter neuromodulation. The newest devices represented here, are intelligent bidirectional devices. They record and stimulate, like that other device for epilepsy that I showed you. And so I think the future of neuromodulation in many areas, not just in psychiatric disease, is going to be this kind of very, very delicate identification of what our best targets are, a period of measurement where we have something like a neurophysiology monitoring unit, sort of like an EMU, but for more broad neurophysiology, and then implantation that achieves intelligent stimulation to be more precise in the way that we treat our patients. And so that's pretty much everything I have to share. I think sort of the conclusion, so certainly this is an important problem to treat, and I don't need to convince this group of that. Historical techniques, I think, were effective and taught us quite a lot. They obviously, in that era, they were not well regulated, not well run. And so we can learn a lot from them, but we need to be much more precise in the way that we conduct our studies going forward. Neuromodulation has been promising in the last 2 decades, but I've shown situations where those trials really did fail. And so we're going to need to be much more precise in the way that we address modulation moving forward. And I think some of the techniques that I've just shown in those last slides really have a lot of promise. And so I'm excited to discuss that and think about that and appreciate this opportunity to speak with all of you. And I've only left us 5 minutes. I thought I would have like 30 minutes left. I'm sorry that I dragged this out. Happy to take questions.
Thank you, Dr. Niemann. That was a stimulating presentation, and it's no problems if you took if it took longer than you expected. I do have one question before I kind of open up to the floor. There's a couple questions in the chat already. My question was, do you notice that with stimulation, lesioning and stimulation have a similar effect long-term as well? Like in the TMS literature, we have low frequency, high frequency stimulation. One's thought to have an inhibitory effect. One's thought to have an excitatory effect. Initially there was some thought that they cause opposite effects, like, one's for anxiety, one's more for, but the more recent literature shows that both of them actually treat the illness in a kind of more of an equal fashion is kind of the thought process now. What's been your experience in terms of lesioning versus stimulation and the law?
My experience is relatively limited. We don't do a lot of lesioning anymore. There are certainly studies on it. I was involved in one case report. We had a patient who had a cingulotomy for depression, and then later was one of the patients treated in the CG25 study. And we reported that she did have a transient response to the lesion and then a sustained response to DBS treatment, but it may very well be that we've just taken out more of the network with that second unit. Had we done it the opposite direction, we might have seen the same effect. I think if they are appropriately targeted and sustained and you're lucky enough to hit that circuit just right, I think the effects are similar.
Thank you for that. There's one question in the chat that I'll ask. Actually, before that, we have some faculty here and some residents on the panel list. Does anyone have any questions before I ask the question that's in the chat?
What about the incidence of seizure after an implantation?
Yeah, so it's remarkably small. If you look at the DBS literature broadly, it's only about 1%. It's exceptionally rare, and notably, in the lobotomy literature, it was also about 1%. So it's pretty rare. I don't see it much in my movement disorders DBS patients. The one exception to that, there is a small series of patients that were treated with dorsal cingulate stimulation. This was performed really for pain by a group at Oxford. And what they demonstrated in that group, for whatever reason, they had a substantial incidence of seizure. That's the one study that I've seen where, 10% of those patients develop seizure. So there seem to be some regions that are more prone to it.
Dr. Niemann, I have a question about public perception and how to overcome a reservoir of negative public perception going forward. If you look at the depiction of psychosurgery of any kind in various media, as recently as Nurse Ratched, which was streaming just recently.
Yeah.
A movie called it was called The Mountain, which was a fictionalized version of Dr. Freeman.
Okay.
Shutter Island. If you go back a little further, of course, you mentioned One Flew Over the Cuckoo's Nest. Suddenly Last Summer, which is a famous play as well as maybe not so famous movie. Those are all extremely negative depictions of psychosurgery, and it's almost always depicted as having some sort of nefarious intention.
Yes.
So how would we ever overcome such a reservoir of negativity?
That is a very good question. I mean, I think there is something fundamental, about surgery generally that is disturbing, grotesque. It is, it's sort of at the limit of experience, and I think it is normal. I say to every patient, hey, we're talking about surgery for things other than psychiatric disease, and I say, I get that no one is excited about brain surgery, right? That is a scary thing, and it sort of should be. I think you have to be very proactive about making sure that you are regulated, that you are on top of things, that you are at every minute sort of checking yourself for your intentions and making sure that you are clear about those. But I don't think we're ever going to get to a point where people welcome brain surgery. I think as we make these things less invasive, that perhaps is a little bit more, certainly the surgeries are nothing like they are shown in Nurse Ratched, but that makes for good Hollywood, I think. It's a good question. It's a problem I don't know exactly how to solve.
Dr. Wong, I think you had your
Yeah, Dr. Niemann. Yeah, I really enjoy your talk. Just a couple questions. So basically, the question is, why do we have mood as human being? Sort of like I feel like the mood dictates how we interact with the environment. So when somebody have a negative mood, is it because the individual has a problem, or is it the environment? And then so is it adaptive to be depressed or to have OCD kind of symptoms? And then so basically, another thing is like as a psychiatrist, I feel like I'm treating I'm treating an individual, sort of like when you do this kind of study, how do you do double-blind placebo-controlled study? How do you control for life? Sort of like you operate on somebody, and then they have this self-suggestion. I went through all this trouble, I should be getting better. And then they, I don't know, win the lottery, find a new girlfriend, their life change, sort of how I feel like it's kind of very hard to control for those life factors to do a perfect study.
I think that's true. I mean, I think it is, and that has been a problem with all of these studies, is that it's exceptionally difficult to measure mood in a way that is accurate and is not subjective. And to do so, when I was involved in these studies in Toronto, we would round with Helen on the patients the day after surgery, and she would do a PANA scale. She would sort of ask them to rate their mood by sort of judging how much they felt like different adjectives. And it would change moment to moment. And of course, to some extent, it went up when you had 4 people suddenly attending to you and wanting to ask you how you're doing and measuring your mood. Maybe on other days they were tired and their mood went down when we showed up. But for the most part, it was an exceptionally difficult thing to not have to not impose some mood on the patient by measuring it.
I hear you. Yeah.
Yeah. Why we have mood? I mean, I guess, in my thinking about, and you guys can help me with this more than I can help you probably, as I think about the function of the frontal lobe, I think that it is sort of it is phylogenetically, it is primarily a motor system. Motor output is the production of the brain and the frontal lobe in particular. And as a result, I think that, so, I sort of see the, motor cortex as being sort of the simplest movement of one muscle in your thumb. The next level being premotor, which is coordinated movements of reaching. The next level perhaps being, urges or desires to move and do simple things, hand washing, checking things. And then mood perhaps being an overall tendency toward activity in some way, shape, or form. That is organization of motor activity at the highest level.
Yes.
I think the fact that we perceive it as mood, it's such a potent feeling. I just feel lousy today. I feel so sad. That's a very different phenomenon internally, that percept, than I am less prone to movement today, perhaps.
Yeah, and another thing, you mentioned nuclear herbanula. Am I pronouncing it right?
Yeah.
What's the significance of that? Because I heard I read some research found out like ketamine might be working through that nucleus. Would you like to comment on this significance
Oh
of
goodness,
this?
I'd have to review the anatomy. The habenula is, my recollection, has, communications with the anterior forebrain bundle and with the, I don't remember the details of its thalamic connectivity, but the thought was, Chris Hen had this potent idea that, the initiator of mood was very much in the lateral habenula, I think. And so he targeted that. It's a tiny target, and for that reason, the few patients that were treated in that way, I don't think exhibited quite the effect we had wanted to see. But the theory of it, as I recall, and I would have to review it, what was sensible, that by modulating this particular pathway, you might alter the connectivity, you might alter the activity that in the depression circuit.
Thank you so much.
Sure.
I have a real quick comment. Thanks so much for the talk, Joseph. That was wonderful, erudite and very informative. And I think in the end, encouraging with the, I think, specific targeting of really understanding the pathways and the connections, and then using that to inform treatment is where we're going to go. I think we're seeing some evidence now with TMS that you can really ramp up the response to TMS with that kind of approach. So
Yeah,
I think we can keep going. I just wanted to make note for the faculty and residents that may not know this, that there's a long history in our Department of Psychiatry and Neurosurgery of doing leucotomies for severe depression. There was a neurosurgeon here named Grantham before my time. I came in 1975, but he apparently was very active in the 50s and 60s, worked with Dr. Ed Landis, who was the first medical director of the Norton Psychiatric Center, and a faculty member. If you go into our conference room, you can see an oil painting of Ed Landis. He was still here when I came. And Ed, one of the first things that happened when I came here is Ed brought in a bunch of old files. It must have been, I don't know, several file cabinets full of all these cases that he and Grantham had treated. And Ed and Grantham never wrote anything up, didn't know how to do it. And they wanted me to write it up. I looked at it, I couldn't figure it out for the life of me. I sort of wish I would have stuck with it though. This was an interesting piece of history. But since then, I don't know of any neurosurgery for a specific psychiatric condition other than VNS.
Yeah.
We did several cases here prior to CMS's giving this the deep six, and all those cases did great. So I'm encouraged that we would get back to VNS someday. But thanks again, Joseph. It was wonderful.
No, thank you. It's been exciting. I can answer the questions in the panel here.
I was going to say there's one in the chat, so I'll read it for the folks who might not have access to that on their phones. This is from Catherine Marcel. She's a PGY3 resident in our department. What have the long-term outcomes been like for patients you followed who've had a neuropsychiatric procedure? Any trends that you've seen, and which procedures are more effective than others?
Yeah, it's a good question, because that's really what we want to get at. These studies are 6 or 12 months, and that is just a moment in the life of someone with depression. And so, when we have been able to have studies that follow patients out to 5 years, it seems to plateau, that you have some people falling off the Kaplan-Meier curve, but somewhere around 50-60% of subjects retain their effect. And that seems to be true pretty much regardless of the target. It's you know, my impression is that it doesn't matter so much where you intervene in the circuit. If you get it right, then you seem to have a sustained effect. I've certainly seen that in patients with VNS. I have seen enough of those patients that I've changed their batteries, and the batteries last about 7 years. And so I've had patients where I've changed those batteries at this point once. I don't know if I've changed anyone twice, but they all, and several of them have, you know, they forget about it, it runs down, and they find out about it when they realize that they've had a recurrence of their severe depression, and they check their battery and come in. So I think it can be preserved, but certainly that we have more to learn there as well.
Got a comment from Dr. Chris Stewart, who is, I think he had to go a little. He's a faculty member and addiction psychiatrist here. Thank you for a very thorough and engaging presentation. I think that the threshold of evidence is understandably very high for these interventions, making the requirement for adaptation much higher than our interventions. Thank you so much.
Yeah, you know, there's no doubt. I mean, you know, surgery has significant risks. So you wouldn't want to do this unless you had a very high level of evidence driving what you're doing, and patients, I think, should demand that. So yeah, I think that's, you know, something that we need to keep working toward, and I suspect it will not be until we really refine our interventions so that we can feel somewhat more confident about you know, our ability to say, yeah, we got that one right. But before we return to sort of a large multi-center trial.
Any additional comments or questions?
Thank you very much. It has been a pleasure to talk to all of you. I would be happy. I'd love talking about this stuff. You know, if anyone ever wants to ask a question or just come over to my office or Zoom with me and have a conversation about this stuff, I'm happy to do it. And I would, you know, Jesse and I have been working to get this VNS study perhaps someday done here. You know, we would be thrilled to do more of that or to explore other opportunities to work together. So please reach out anytime. Thank you very much.